Good morning, everyone.
The mic's not on.
Can I?
I hope they're turning on our mics.
Thank you. If you could have, please, the seat. We're about to start. Okay, great. Okay, well, welcome to our chronic hepatitis B in focus session here today. We're very happy to have you here. I want to just remind you that this is an interactive session. We really look forward to interacting with you, hearing your questions and your responses. Throughout the presentation, you're going to be seeing QR codes in which you are going to be asked questions for response. We really appreciate you having your phones ready for scanning the questions and responding to us. Also, there is a QR code right now on the screen. If you could please scan that. It has a few questions about hepatitis B up front. We really appreciate you filling that out at this point. Here's the QR code again. Okay. Thank you, everyone. I'm Mandana Khalili. I'm a professor of medicine here at UCSF, University of California, San Francisco, and chief of clinical hepatology and director of hepatology research. I'm joined by my esteemed colleagues, Dr. Paul Koh and Dr. Nora Turow. Paul, would you mind introducing yourself, please?
Sure. Hi, Paul Quo. I'm a hepatologist at Stanford University. I direct the liver group.
And Nora?
Nora Turow. I'm a transplant hepatologist at the University of Southern California. Nice to be here.
Thank you. Just wanted to mention that the program is intended to provide disease awareness education, and so any questions you may have about disease states of chronic hepatitis B will be addressed here. But if you have any clinical or scientific questions that are related to GSK medications, please don't hesitate to reach out to the representatives that are also here as well. Here are our disclosures. The objectives of this session are that we will review critical barriers and unmet needs in chronic hepatitis B. We'll understand and interpret AASLD guidelines, the new ones that just came out on Tuesday, for managing patients with indeterminate phase. We will also apply clinical decision making through a patient case study and panel discussion. Just as a reminder, chronic hepatitis B is quite prevalent. 1.8 million Americans in the United States are infected with chronic hepatitis B. It predominantly occurs in individuals who are of foreign birth, about 80% of such, and also majority of the individuals who are infected are of Asian ethnicity. We still have a high prevalence of hepatitis B that hasn't changed over the years, and about 17,000 new chronic infection cases were reported in 2003, most of whom were within the ages of 30 to 50 years. If left untreated, hepatitis B is a progressive disease. It progresses to end-stage liver disease over time, over lifetime, and also has a high risk of development of hepatocellular carcinoma. Globally, we have about 1 million deaths attributed to chronic hepatitis B. And also, it is the most common etiology for hepatocellular carcinoma, occurring in about 50% or more of individuals globally. Okay, so we're going to start off with our case. This is on. She is a 38-year-old female born in Vietnam, moved to the United States at age 15. She doesn't have any siblings, and she works as a warehouse manager. On routine testing or screening, she was found to have hepatitis B surface antigen positivity. This was incidental, and she underwent then viral load testing, which showed that the hepatitis B viral levels were elevated at 1,500 international units per milliliter. She has a family history of a father who died of liver disease, mostly attributed to alcohol-related etiology. Mom does not have any known liver disease, and the status of hepatitis B in the family is unknown. She doesn't smoke, uses alcohol occasionally, and has abstained from using alcohol since the diagnosis of hepatitis B. She doesn't have any significant comorbidities and is maintaining an active lifestyle with her physical job working at the warehouse. She's then referred to you as the hepatologist for further evaluation and management. When you're seeing the patient in the clinic 4 months later after the initial assessment, the patient's feeling well, doesn't have any symptoms, concerned about her diagnosis quite a bit as she's getting married in the next few months and wants to have more information about what to do. And she's very concerned about having children. Her vitals are stable. Her BMI is mildly elevated at 25.3 for an Asian woman. She is overweight, normal being less than 23. Her physical exam was unremarkable. She didn't have any stigmata of chronic liver disease, and you proceed with doing laboratory assessment. In laboratory testing, her surface antigen is positive, as previously stated, core positivity. Hepatitis B E antigen is negative with an E antibody positive status. You repeat the hepatitis B DNA levels, and now it's 2,500 international units per milliliter. The liver tests are done, and the ALT is slightly elevated at 31, normal being less than 25, AST is 30. The platelet counts are on the low level of normal at about 160. Okay, so our first question is about what phase of chronic hepatitis B infection does this patient fall under? Is it immune tolerant chronic hepatitis B? Is it immune active? Inactive chronic hepatitis B? Is it hepatitis B reactivation? Or is it something else? Please proceed with answering the questions. Here's the QR code again. Okay, we're now looking at the responses that are coming through. Excellent. So we seem to be having majority thinking that this is an immune tolerant phase of infection, about a quarter immune active. Some think that it's something else. Okay. I think we can move on. So immune tolerant phase of chronic infection is the predominant response. Okay, so I'm going to turn to my panel and just reminding you that the patient is asymptomatic, very concerned about her hepatitis B infection, getting married, and so she wants some information about what happens. And this is pretty common in our settings. Paul, would you mind going ahead with the first impressions?
Yeah, so she comes to us and her viral load doesn't, and her presentation doesn't neatly fit into any particular category. I think that's the most important thing here. And, you know, hepatitis B is not static. So a new diagnosis, she has a viral level initially that was a bit lower than we would normally consider treatment. Then she goes a little bit above. Her AST and ALT aren't particularly elevated. You know, I am thinking this is somebody that we're going to have to phenotype a little bit more. And again, you know, one doesn't evaluate someone in hepatitis B just at one visit. It's a process as you get to know your patients. So in this particular case, I am thinking that we're going to need a little bit more data as well as some longitudinal help, and talk to her a little bit more about her plans as well as to what she wants to do as we move forward with the plan to manage her hepatitis B.
Thank you for that. Nora, I know she's very concerned about fertility, about getting pregnant, but also concerned about passing on the infection to the child, and has heard quite a bit, from her community about the importance of, or the worries about hepatitis B infection. In this type of a setting, how would you counsel the patient?
Well, she's getting married, so the first thing I'd want to know about is her partner. Her husband-to-be or her partner-to-be. We want to make sure that they're protected, right? So the most important thing is to protect those that are in the household with vaccination. But then for her, the mother-to-child transmission risk is really something that happens perinatally, and we know that the risk is really related to the maternal viral load. Her viral load is far below the level that is of risk. So the risk that's defined by all of the guidelines, including WHO, is a level of 200,000 IUs per ml. So she's far below that level. So I would inform her, let her know that actually with that level of viral load, that what we do to the baby at the time of birth with HBsAg and vaccination is going to be highly protective and prevent mother-to-child transmission. So we would not specifically initiate therapy during pregnancy in this case because the viral load is low. Now, she's not pregnant yet, and Paul already highlighted that this is a dynamic disease, right? So it's always recommended that when a woman becomes pregnant is that you retest them to see where their viral load is then, and then adjust your decision making. But at this point, I'd reassure her that, first of all, we have very good ways to protect her baby. Now that we know she has hepatitis B, that we can use treatment in her case, we can protect the baby through vaccination and HBsAg, and try to reassure and let her know that we will be reassessing when she actually gets pregnant.
Excellent. So I think, Paul, you mentioned that this is an in-between phase. And which in-between phase are we talking about?
Yeah, she's not immune tolerant. Okay, so she doesn't have a super high viral load. So she's somewhere between inactive, right, and then maybe a little bit of reactivation, maybe a little bit, although I again think she's more transitioned to the point where she's somewhere in the indeterminate, what we call an indeterminate phase, just bouncing around, and sometimes it takes a little while to decide where it is that they ultimately land, but she's somewhere between those phases.
Got it. Thank you. Okay, so let's remind ourselves about the phases of chronic hepatitis B infection. As it was mentioned earlier, patients in the immune tolerant phase, typically children or early adulthood, tend to have really high hepatitis B viral levels. We're talking about 10 to the 7 and higher, and oftentimes very normal, so persistently normal ALT levels. And that transitions in time to an immune active phase in most cases, in which the time frame of about mid-30s or so, you're seeing this kind of fluctuations of ALT levels into the abnormal range. The viral load does come down, the E antigen still remaining positive, but then it can transition in time over to an E antigen negative state, in which case the viral load can be low at less than 2,000, so immune inactive, or it can go back up and fluctuate into the abnormal range greater than 2,000, in which case they are now hepatitis B E antigen immune active phase of infection. And then, of course, when you do have hepatitis B surface antigen negativity, as well as normalization of ALT, viral load is often at that point undetectable. That is the place where we have had a hepatitis B surface antigen negativity or seroconversion, in which case the surface antibody would be positive. Okay. Now, one more word about treatment indications. Typically, we think about treatment indications at this point in the setting of hepatitis B that is E antigen positive, immune active, which means the viral load is above 20,000, ALT abnormal, and also E antigen negative immune active phase, where now we're looking at hepatitis B greater than, a viral load greater than 2,000 and abnormal liver enzymes. But oftentimes patients fall into, like this patient, into an indeterminate phase on follow-up. And the indeterminate phase are in between these phases where we may have elevation of the viral load, but normal, persistently normal liver enzymes, or flip of that being that you have abnormal liver enzymes with the viral loads of less than 2,000. And that occurs in about 40% of patients in general. So how do we manage these patients? Okay. So we now have an opportunity to phenotype this patient more. Paul indicated we would want to know a little bit more about her. And as a reminder, patient's viral load fluctuated between 1,500 and 2,500. ALT is 31. What additional tests should be performed to optimize ON's clinical care? Should it be VCTE or FibroScan, vibration-controlled transient elastography? Should it be abdominal ultrasound? Do we want to test for HIV, hepatitis C, hepatitis delta? Do we want to test her lipid profiles in the setting of her being overweight, and or all of the above? Please again proceed with your choices, and we're going to look to see what the responses are here. Okay, perfect. Well, we seem to have a consensus. All of the above seems to be the answer. Okay, let's go to the next question. Well, she's certainly got more phenotyping done. She had a FibroScan that shows the liver stiffness was 6.8 kilopascals. The CAP was 275. Abdominal ultrasound showed that she has mild echogenicity of the liver, normal blood vessels, bile ducts, no significant abnormalities, no nodularities, no splenomegaly, no ascites, etc. And additional laboratory testing shows that she's hepatitis C, Delta, and HIV negative. Triglycerides are elevated at 340, but the rest of her testing is normal, including hemoglobin A1C. So we have this now. Okay, so a few questions for our panelists. Well, can you tell me a little bit about your reflections of what you see here on the FibroScan results?
Yeah, so looking at our FibroScan result, you look at the liver stiffness measurement. You know, we used to be in viral hepatitis, particularly hepatitis C, stage 0, 1, 2, 3, 4. Now we sort of categorize as minimal, low-level fibrosis and higher levels of fibrosis. So she's clearly on the lower end here, and I would tell her that. So that's her liver stiffness measurement. Then you have the CAP score, which is controlled attenuation parameter, a reflection of hepatic steatosis. And again, in 2025, this is metabolic health is something that we must pay attention to regardless of the prevalence of any or presence of any other liver disease. And so I am going to be counseling her independently of the hepatitis B decision that we need to focus on optimizing metabolic health.
Mm-hmm. Excellent. And Nora, we saw that the platelet counts were about 160, so it was sort of low normal level. Are you surprised with the findings that we see on the FibroScan?
Well, I'm reassured, I would say, because I definitely was concerned that she may have a more advanced stage of fibrosis based on the platelet count alone. So this is reassuring data. I have both an ultrasound and, of course, the VCTE that's assuring me that she doesn't have evidence of advanced fibrosis or cirrhosis. So that's good. I mean, she's young, so you maybe had a lower concern, but I always pay attention to that platelet count because it really is an important clue to advanced disease. The other thing that I think is, I just wanted to emphasize is that, strictly speaking, from the point of view of do we do an ultrasound on every patient with hepatitis B, I think comes into play here, right? Because we have reasons to do ultrasound where we're doing it for surveillance in anyone who has surface antigen positivity. If we were thinking about it in that context, she doesn't strictly meet guidance based on her age, but her family history is somewhat important here because her father had cirrhosis, ascribed to alcohol, but we don't know if maybe hepatitis B was a player. So I view that history as being important also. So we think about her as somebody who's going to need surveillance despite her age. And then, of course, we're using it in a way to help us understand how about the metabolic dysfunction associated liver disease, right? So both the ultrasound and VCT CAP tell us that she has mild disease there.
Now we know that the prevalence of these two conditions together actually is pretty high. We think it's about 30 to 35% of patients with chronic hepatitis B have overlaying steatosis, and majority of these patients, because it is not related to viral factors, have metabolic dysfunction, diabetes, hypertension, hyperlipidemia that is leading to steatosis in the liver. So this is not an uncommon scenario that we see. Now I'm going to ask you two questions that just came to mind. One was about the family history of alcohol intake that was there, and I wonder, knowing that we see some degree of fat in the liver, and we know that she doesn't have any other metabolic dysfunction except for the triglycerides being elevated, which hopefully was done fasting, because oftentimes that's a problem with that. When we see that, are you concerned that there may be an issue going on as well with alcohol use? Would you suggest that in the setting here we would do a biomarker of alcohol testing, or we would just leave it alone and move forward? Paul?
So I educate all hepatitis B patients about alcohol use, and I'm a huge fan, by the way, of the Canadian guideline and recommendation, because I think that they have done a really nice job of showing the contribution of alcohol not just to liver-related outcomes, but to all health-related outcomes, which is basically you should limit your alcohol to 2 drinks or less per week. And so in this particular case, this is, again, a dynamic process. She has said that she has stopped. I would tend to believe her, but, if her AST stays higher, or, it wouldn't hurt. Sometimes I actually will have a shared discussion and just say, you're drinking, let's just draw a PEth level just to see what the level of alcohol that you're being exposed to, because again, people say it may be 1 glass or 2 glasses of wine, et cetera, et cetera. I'm a big believer in quantifying, like for wine, how many bottles do you drink, because that helps.
Thank you for that. Excellent. Okay. So we're going to move forward and think a little bit more about, okay, what next? We know that there may be a potential dual etiology going on here. Is it meaningful? Is it important? How do we prognosticate? How do we consult the patient? So what additional testing strategies could you use to guide ON's clinical care? Enhanced liver fibrosis, or ELF, magnetic resonance imaging, or MRE, quantitative hepatitis B surface antigen, or liver biopsy? Please proceed with your answers. Okay. Excellent. So we seem to be landing predominantly on quantitative hepatitis B surface antigen testing. That's fantastic. 3/4 of the people asked for that, about 1/4 ELF, and then a bet on liver biopsy. Okay, so what about next steps? What would your choices be? Paul, let's start with you first, and then we go to
for guiding, so I would order a quantitative surface antigen in this case, also to kind of help, again, assess what the contribution is of hepatitis B in this person who has metabolic features as well. And again, in the background, I'm having, assessing her life situation as well. When we contemplate not only as how we're going to manage and follow her, but also whether or not you would offer her treatment at this time. Again, doesn't neatly fit into any of the treatment categories, but this is, again, an area where shared decision making, I think, which is so important in the new guidance, is going to be very important.
Nora, with our recent guidelines that have come out, there's many of the areas that really does require shared decision making for the patients. When you approach shared decision making, first, what do we mean by that, and how do you approach that in talking to the patient?
Yeah, so the intent with shared decision making is, first of all, you have to provide the information about the disease. So in her case, we'd be reviewing what is the potential risks of untreated hepatitis B. We'd want to discuss what is the commitment needed if you start treatment. What are the side effects related to that treatment? And then the alternative is to also talk to them about, potential risks or benefits of being untreated. But most importantly in the shared decision making is to hear from her. Help her to understand where she's at, what her concerns are. And because she's relatively newly diagnosed, she's getting married, she has concerns around mother-to-child transmission, that may dominate in terms of her concerns. And so a shared decision making should reflect that, right? So it's really about understanding their preferences, their concerns, their desires. But you have to give them the full information about the treat, no treat, and do it in a way that is very balanced, so that we can really have them infuse their decision, their component of preferences and desires and concerns to make the final decision.
The prior guidelines were more strict about decision making regarding treatment. The newer guideline seems to be giving more and more permission for the providers to really have a discussion, as you indicated, with respect to shared decision making with their patients, and kind of being a little bit more permissive in allowing us to make those kinds of decisions. Do you have any reflections on that?
I absolutely want to convey that the new guidance is expanding the opportunities to treat. We really did it recognizing that there were kind of gaps in the prior guideline in terms of, areas where it was kind of complex and the messaging was less clear. She's a perfect example of where the guidance before said, this kind of patient you should monitor, and they'll kind of declare themselves over time. They'll either become, ALT will go up higher and the HBV DNA will go up higher, and then you'll say, okay, they have immune active disease, I treat. Or everything gets very low and you say, okay, they have inactive hepatitis B, because she's straddling those two phases right now. But now the guidance says if you have someone like this patient, that you should talk to them about, again, what it means to be treated, about not being treated, but really actually is encouraging treatment. And part of it is, I think when we're unsure, we know that treatments are so safe and easy and cheap generally to use, that if you have uncertainty, that we're sort of saying in the guidance, through this shared decision making, we are suggesting treatment. But we are actually suggesting treatment in a patient like this, right?
Yeah.
So to make that point.
Thank you for that. Okay, let's move on now to the results. So the hepatitis B surface antigen quantitative value comes back at 1,200. Okay. So what are your thoughts about that, Paul?
Well, I just want to say just what Nora was saying, that she's straddling, but maybe a little bit more toward active than inactive carrier. And so then you really do have to sit down and have a discussion with her. And in someone like this who's considering having children, sometimes they're very worried about transmission. Her viral level is such that really her risk of transmission is quite low. It's been my experience that most women who are considering children at this time, they don't really want to be on a medicine during the first trimester if they can avoid it. So, monitoring would be perfectly appropriate. Again, during the pregnancy, we would monitor, and obviously if her viral level went up during pregnancy to which does happen, not terribly commonly, but certainly could go up to the threshold of 200,000. Then you would put somebody on treatment. But that's the conversation that I would be having with her. The therapies during pregnancy that are perfectly safe, excellent safety record for tenofovir and now both tenofovirs.
Yes. Excellent. Nora, what do you think about, the patient thinks, what I've heard of people who've gotten sick after pregnancy, they didn't get treated, and their hepatitis B got worse. If I don't get treatment, what happens to my hepatitis B following pregnancy? Is there any particular suggestions or recommendations or thoughts that you want to impart?
Well, we recommend that all women, we know that during pregnancy, often many diseases become less active, but there's a risk for a postpartum flare. So the recommendation in the guidance is that regardless of whether if the woman is not on antiviral therapy, that you would monitor their viral load and ALT levels every 3 months for the first 6 months, and I do it for a full year, and then after that go back to every 6 months monitoring. And the purpose in doing that is to identify women who may be having a flare, where you may consider initiating treatment at that time. So reassure her that she's going to be monitored in the postpartum period, and if there's any evidence that her hepatitis B has become active, that we would move forward with doing treatment.
Yeah. So I think we touched on the hepatitis B surface antigen levels being important in both determining and confirming phases of infection. We talked a little bit about treatment initiation and the need for that. We haven't talked that much about monitoring and also the natural history of disease with regards to hepatitis B surface antigen quantitative levels, and also the risk for disease progression. So maybe briefly, Paul, if you could let me know if there's certain levels or threshold that you worry about with regards to progression of disease or risk of liver cancer, for example.
Yeah, so we can use hepatitis B surface antigen. In fact, it's a marker similar to hepatitis B DNA levels. And indeed, you know, with the REVEAL study, there was this wonderful data set that showed us that a biological gradient that occurred in risk for hepatocellular carcinoma. Well, you know, the same gradient actually exists with surface antigen. Higher levels of surface antigen are associated with higher rates of liver cancer. And so, again, her level it's not terribly high, but it's, again, not in the inactive range. And that, again, affects your shared decision making.
Right. So you think about less than 1,000 being more in the inactive range. You think about greater than 1,000 being more indicative of risk progression. Any other additional thoughts, Nora, about the value of the surface antigen?
Well, I think it helps a little bit. I think she's still on the lower end. You know, she's almost at that like 1,000 cutoff. So yeah. For me now, I'm really thinking she is more like inactive hepatitis B. Her surface antigen is on the low side. Her viral load is bouncing around 2,000. And I have another explanation for her ALT elevation, right? So I clearly think she has some component of steatotic liver disease. So I might focus on actually trying to address that with her. Mm-hmm. And just tell her that we're obviously going to continue to monitor both her HBV DNA or ALT level. That what we'd like to do is now focus on the steatosis, mm-hmm. treat her hypertriglyceridemia, for example, mm-hmm. and really maybe try to optimize her weight before pregnancy. Mm-hmm. Those would be the things that I would chat with her about. And I'd be interested to see how that affects her ALT. Mm-hmm. And if it normalized with those interventions, that'd be helpful for future. It doesn't always work out, and sometimes you have to say, well, maybe they have fatty liver, a component of it, but their ALT is still elevated, I'm going to treat. But I'm just saying that would be my approach with her because she's young, and I do think that the data are aligning a little bit more towards her being in the inactive camp. Mm-hmm. But it shows you that it's not black and white. Mm-hmm. And so I'll go back to the guidance which says she's still indeterminate. So if she's indeterminate and you, after some discussion, say, I think I want to treat this patient, treat this patient.
Now, she's smart. She goes into the Google and, and she's searching away, and she sees that there's data that suggests that when you have fat in the liver, steatosis of the liver, your viral markers may be lower. So what happens if you're going to treat my fat in the liver, if you're worried about that, and my virus is now going to reactivate or go up? So she has that question for you. Any thoughts about that?
Well, first of all, don't go to Google as often as, try not to go to Google, but you will anyway. And now it's, the GPT chat or whatever. But I would say to her, you have two diseases that we're trying to manage. I still feel like we should focus on treating your metabolic disease and the components of that. That's important for your long-term liver health. And if your viral load were to go up, it may be because the fat has changed. It could be other things, right? Yeah. It's a dynamic disease. We acknowledge that it's going to change. And so instilling in the patients this idea that it can change over time, we have to adjust our thinking about your treatment over time is the message, right? So if it goes up, we'll reassess and maybe you'll need treatment at that time.
And the important thing is you will be monitored. Yeah. I mean, that I think is the most important thing. As things evolve, we will continue and again can intervene appropriately, whether it be through a viral treatment or through a metabolic treatment. It can be both.
Mm-hmm. Great. So I think one of the things that comes up in our setting, and this is not uncommon, patients are learning more and more about the various issues surrounding hepatitis B, and they may ask these questions. And so I think while we think that simple fat may not necessarily have a negative consequence, in the setting of steatohepatitis, we do worry about progression of liver disease and risk of liver cancer. And more data is now showing that the combination of having systemic metabolic abnormalities, specifically how we define now MASLD, is also an additional risk for developing hepatocellular carcinoma. So while we don't have all the answers, I think it's things to keep in mind that there's still two progressive diseases if there is evidence of steatohepatitis, and certainly warrants management. Okay, so we've touched on this actually quite well. So again, surface antigen quantitative testing is important for the purpose of our categorizing in these difficult cases, the phase of the infection and maybe determination of necessity for initiation of treatment. It could also predict spontaneous hepatitis B surface antigen seroclearance, so less than 100 levels, 100 and less are pretty predictive of that. It could aid in assessment or counseling of the patient with regards to progression of disease, but also monitoring it over time could also be very helpful in that consultation. And then as well, with respect to treatment responses, we do have data to show that it could certainly predict response to treatment and surface antigen seroclearance following treatment. And then one more thing is deciding to come off of the treatment as well. So if you have low levels, it may be safer in those settings to come off of the treatment should the patient wish to do so.
If I could just comment on that. So I think that at least in the United States, I would say I think in other parts of the world, perhaps they've been using the surface antigen quant more integrated into their practices for longer. For us, it's been really, we're sort of only had availability more recently, and so I think we're trying to figure out where it fits in our practice. I really like it in the patients who have inactive hepatitis B, where we know the next phase for them could be functional cure.
Yes.
Those ones I'm absolutely getting a surface antigen every year to monitor kind of how they're moving in that direction. So I think that's very helpful. You highlight the withdrawal, so I'll just say that the new AASLD guidance also spoke about that. It actually advises against doing withdrawal until people lose surface antigen, but if you're going to do withdrawal based on shared decision making with your patient who really wants to come off, then we strongly recommended the use of surface antigen to be a guide, and the level we recommended was less than 100. So again, another place where surface antigen is very valuable.
Absolutely. Any thoughts?
No, I just that I agree. I think that surface antigen can be helpful for patients as well. It can help with compliance with therapy if the surface antigen keeps going down slowly each time you see them. No more than an annual basis, but it's very useful for patients as well. And if it's very low, that's also very helpful in making treatment decisions as well.
Absolutely.
You know, I just want to say, Paul, I think that is a very untapped kind of reason to use surface antigen. Because, you know, we have many patients who are on treatment and their HBV DNA levels are very well suppressed. And I don't know about you, but I have patients who then decide that they're cured and they stop their treatment, right? And it happens in my clinic. I'm sure it happens in yours as well, right? They just have it. But then if their surface antigen is also being done concurrently, that's kind of a marker for them that they still have infection.
Virus.
And I think does really reinforce this idea of needing to be adherent. So it's a great idea. I think we haven't really made that kind of that awareness, but I love it. I think that's a great idea.
Fantastic. Okay. So we're coming to the end of our presentation. We'd like to leave some time for question and answers. But just again to reiterate that hepatitis B is an important condition in the United States and certainly globally. That if left untreated, it can progress to cirrhosis and hepatocellular carcinoma as a risk. About 40% of patients fall into this indeterminate phase of infection that we discussed. And so in those cases, we tend to really want to understand better the stage of the disease, the activity of the disease, as well as making decisions regarding treatment with respect to risk for other conditions such as hepatocellular carcinoma. That hepatitis B quant surface antigen is helpful, is now commercially available, and is recommended as part of assessment or evaluation of patients with hepatitis B within our current guidelines. And as shared with you by all of us, there are different means by which we can utilize this testing and also monitoring over time. And that achieving functional cure may reduce the risk of all of these complications, and it's an ideal scenario for management of patients with chronic hepatitis B and a good endpoint.